So I would like to thank you for the opportunity to be part of the C20 summit. On behalf of Kale Association for Combating Obesity, I am honored, Ghalia Abdin, an assistant professor for clinical nutrition at King Saud University. I studied my PhD at Imperial College London with an interest of weight loss mechanism, appetite, and ingestive behavior. In addition, an acting member in several associations and scientific committees in Saudi Arabia. I am honored to present at the C20 summit representing my country in the field. Today, we're going to discuss a very important topic. It's about, should we recognize obesity as a disease? To give some highlights about Kale Association, it is the first in Saudi Arabia as charitable association for obesity. It was established in 2010, located in Riyadh City, and we are a member of the World Obesity Federation. Our vision, to reach our services to all regions of the kingdom, coinciding with the Ministry of Health plan under the National Transformation Program 2020, fulfilling the 2030 vision. Obesity, the problem of obesity is complex. It includes food production, social influences, food consumption, individual psychology, individual activity, environment, and biology, and more to learn in the future. Some numbers to share about the prevalence of obesity for adults, and it can show here that Saudi Arabia is among the highest and worldwide. It was estimated in 2016 from the World Health Organization report that 2.7 billion globally are having either obesity or overweight, and 1 billion of them are having obesity. Might trend to go up till 177 million of severely obese patients in 2015. It has been the obesity prevalence has been tripled from 1975 to 2016. The estimated annual medical cost was estimated in 2008 with 147 billion, having that obese patient is costing more than 1,400 than a normal person. Our objective at C20 is to recognize obesity as a disease among the G20 countries by 2020. By recognizing obesity as a disease, it will help in provide optimum management strategies, assure equal access for treatment in governmental, private hospitals or sectors for healthcare, and covered by insurance completely. Increase the availability to all treatment modalities, and promote implementing strategies for healthy environment. Countries that recognized obesity as a disease till now, it was Japan, Netherlands, Portugal, Italy, and Germany lately. Some organizations that recognize obesity as a disease, starting with the Scottish Intercollegiate Guideline Network in 2010, to the American Medical Association in 2013, Canadian Medical Association 2015, and the World Health Organization in 2017. In March 2017, the World Obesity Federation concluded that obesity should be officially recognized as chronic, relapsing, progressive disease. Moving to Saudi Arabia, quoting the strategic objective from the American Medical Association, recognizing obesity as a disease will help change the way the medical community tackles this complex issue. The Vision 2030 represents a structural shift in the Saudi healthcare, suggesting quality life programs, and this will be achieved by doing the following, or by implementing the following objectives and initiatives has been proposed for obesity. Promote prevention against health risk. Improve public health services with focus on obesity and smoking. Decreasing of smoking and obesity incidence by 2% and 1% from the baseline, respectively. Now, to do this, a private sector and stakeholders all in all have to work hand in hand Increased recognition of obesity as a disease caused by modifiable disease agent possibly will encourage changes to perception and increase cooperative efforts to reverse the obesity epidemic. Governments, not individuals, can change the food environment through regulating industries, implementing taxes, and controlling availability and affordability. Governments also influence the built environment and can encourage changes to physical activity at the population level by, for example, improving cycling infrastructures and lawmaking for employers to reduce sedentary work practices. So until obesity is globally or universally recognized as a chronic disease, not a lifestyle choice, its prevalence is not likely to be reduced. A special thanks for my colleagues that without them this wouldn't happen. Dr. Madawi Al-Dwayan, Ms. Hanadi Al-Ouda, Ms. Haifa Al-Fadl, Ms. Amina Al-Shammari, and Ms. Fatima Al-Gumez, and of course, the CALE board members. Thank you very much. So what's going next for us as a program? The next presentation will be about obesity is a disease. What are the available facts presented by Prof. Carl Leroux? Prof. Carl Leroux graduated from medical school in Pretoria, South Africa. He obtained his PhD from Imperial College London, where he later took up as a faculty position. He moved to University College Dublin for the chair of experimental pathology, and he is now a director of the medical medicine group. He currently coordinates an innovative medicine initiative projects on obesity. He previously received a President of Ireland Young Researcher Award, Irish Research Council Laureate Award, Clinician Scientist Award from the National Institute Health Research in the UK, and a Wellcome Trust Clinical Research Fellowship for his work on how the gut talks to the brain. You're most welcome, Dr. Carr. Prof. Carr. Please.
Thank you very much. I'm a clinician scientist that see patients every day, and my job is to try and understand how to best treat people with obesity. And this question is very important, whether or not we really need to consider obesity as a disease and what are the available facts. This painting that you see is very famous from Botticelli that depicts Dante's Inferno. And really what we have done in the last several centuries is we've been trapped by this idea as depicted by this and written down by Dante, that obesity, either sloth or gluttony, are sins. And therefore a sin is a willful act. And therefore, we have not been able to think of obesity as a disease because instead we've been thinking of this as a sinful act. And that has held us back in how we can treat our patients. So next slide, please. These are my conflicts of interest, and we work with lots of different companies, medical companies, surgical companies, nutrition companies, because we do not think that obesity is one disease. We think it's multiple diseases, and therefore we need more than one treatment. It's unlikely to have a silver bullet that's going to treat all people with obesity. Next slide. But here's the challenge that we have. You and I know people, our friends and our family, that have gone on diets in the past. And when they lose weight, they come back to us and say, you know, I've never been as hungry as when I'm on a diet. And then what we see, what will happen is that they will regain the weight when the diet stops, and they'll end up being a little bit heavier than they were before. So we know that this is not the treatment. Asking people to move more and eat less is not the treatment for the disease of obesity. Next slide. Because it'll be a little bit like asking somebody who has swelling of the legs when they have pitting edema. So this is a water collection that under the legs, to say to somebody that has this excess water, what they should do is drink less water and urinate more. So drinking and urinating more, drinking less and urinating more is not the treatment for edema or swelling of the legs. In the same way as eating less and moving more is not the treatment for excess fat collection under the skin. In fact, what we do if we see somebody with edema, next slide, is that we think about the differential diagnosis. We try to work out what is wrong. Is it a problem with the liver, or is it a problem with the kidneys? Is there a problem with the heart? Because depending on where the problem is, our treatment strategies changes dramatically. Next slide. So if we ask ourselves, is obesity a disease? Next slide. We have to go back and look at the environment, because we hear so often that obesity was not a problem 50 years ago. So why is it a problem now? This is a very famous study from Sweden where young twins who were separated at birth were reunited when they were teenagers. And what you will see in the top slide is these are twins who do not share the same identical genetic material. So they are non-identical twins. And you can see they have different hair colors, they have different heights, and they have different weights. But look at this slide at the bottom. These are twins who are genetically identical. And what you will find is that they have the same height, they have the same hair color, and unsurprising, they also have the same body weight. And this is despite them being raised in completely different environments. So although the environment is important, your genetic components determine how tall you're going to be, and your genetic components determine what your body mass index is going to be in the long term, helping us understand that obesity is a biological disease. Next slide. So that has been recognized, as Galia said, by the World Health Organization and many others. Next slide. But now we have to ask ourselves, if obesity is a disease, does that mean we need to treat everybody just because they have a body mass index, which is the measurement we use for obesity, your height divided, or your weight divided by your height squared, if it's more than 30. And here we have a man who is very heavy, but he's very healthy. So it means that if we are going to treat obesity as a disease, it does not mean that everybody needs the same treatment, or in fact, that everybody needs intensive treatment. Next slide. Rather, what we do when we diagnose new diseases and approach it is we treat the people who benefit most, such as this man who is less heavy, but he's more sick. So the treatment for obesity, the aim is not weight loss. The aim, in fact, is health gain. So understanding that obesity is a chronic disease, and we do it in exactly the same way as we treat all other chronic diseases, will certainly help us. Next slide. So here is some innovative treatments that has been used by Professor Steve O'Reilly and others, where this boy had a leptin deficiency. This is incredibly rare, but look at what happens to the same boy once the treatment has been given. We did not change this boy's environment. We did not give him extensive cognitive behavior therapy. All we did was address the biology. And I think that is where the breakthroughs will come. Next slide. But first of all, we have to ask ourselves, which organ are we treating? Because we already know that the treatment of fat tissue is not our focus. The treatment of obesity as a disease is our focus. So where does the disease of obesity originate, and what should we be targeting? Next slide. And it's when we look at gene-wide association studies that we see that 80% of the genes are located in the central nervous system. Next slide. And when we delve into the brain, we see it's the parts of the brain that you and I cannot control by thinking. These are the parts of the brain, the so-called primitive parts of the brain, that controls our body temperature. And none of us that's on this call today can sit there and think our body temperature 1 degree higher or think our body temperature 1 degree lower. In the same way, none of us can sit there and think ourselves less hungry or think ourselves more satisfied. So understanding that it is the part of the brain that we don't have control over that is in fact responsible for hunger and satiety helps us also understand the biology of obesity and helps us target our treatments. Next slide. So we're going to hear more about treatments from Dr. Alex Miras in a moment, but what we see is that any treatment, be it diet approaches, medication, or surgical approaches, can only be successful if it reduces these symptoms of obesity. And the two important symptoms are excess hunger or reduction in satiety. And only when we change these symptoms are we able to change the behaviors of our patients in a natural way. Next slide. Of course, the brain is interconnected, so changing the primitive parts of the brain also projects forward and allows people to have more control. So what we are suggesting is that we have to start with the biology, but we can also add in the psychology after our treatments. So we have an holistic treatment, but where we have made a mistake in the past is thinking that obesity is a lack of moral fiber, that there's something wrong with our patients, and therefore we have to teach them to be better citizens, and we have to teach them to behave in a better way. In fact, now we understand what we first have to do is change the biology and then add the psychology to get more benefit. Next slide. So if we think about all of biology is governed by set points, and your fat mass is no different. Your body wants you to have a certain number of fat cells that sit under your skin. And of course, if you're in a bad environment where you're not exercising enough, you're not sleeping enough, you have a bad diet, then you're going to push up this set point. But now what we want to do is change this. Next slide. By using, for example, next slide, lifestyle changes, not calorie restriction. So we want to have better diets, better exercise, better sleep to reduce the set point, to allow the body to want to be 5% less heavy. Next slide. We're also going to hear from Dr. Miras how we can use new medications, and the pipeline is incredibly exciting about what we will be able to do in the next few years. Next slide. And we also can use surgical treatments to reduce the set point. All of these treatments work through biology. Next slide. So what is our typical treatment algorithm? Next slide. We start by giving people self-directed lifestyle changes, public health messages to eat healthy food, to take exercise. Next slide. But if that does not work, we need professionally guided lifestyle changes. Next slide. We can also escalate to add medication. And next slide. If that does not work, we can use surgical treatments. Next slide. And finally, we can combine our strategies. A person doesn't have to deserve the treatment that they're having, but in fact, we need to provide the treatments that is correct for the patient. So this is personalized medicine, getting the right treatment to the right patient at the right time. Next slide. So ultimately, what we understand is if you are lean, the more food you will eat, the more satisfied you will be. But in fact, if you have the disease of obesity, next slide, this curve is shifted to the right, and you need to consume more calories before you feel satisfied. But what we want to do with our interventions is turn that into the next slide, where people consume fewer calories and yet feel satisfied. Next slide. So all our treatments are based on biology because the disease that we are treating is a biological disease, it's a chronic disease, and therefore we need to continue our treatments in the long term to allow the new set point to be reached and maintained. Next slide. Please allow me to thank the team at home that's doing all the hard work, including Dr. Word Al-Najim, that will also talk to us in a few minutes. Next slide. our international collaborators, many of whom work in Saudi Arabia. Next slide. And we've set up this website called It's Not Your Fault, specifically to communicate the science of obesity and to allow our patients to understand that this disease is not their fault, but it is their responsibility. And it is my responsibility as a healthcare provider, and it's your responsibility as policymakers to get the right treatments to patients to allow us to have health gain. Thank you very much.
Thank you, Dr. Carr. Thank you so much for such an interesting presentation. Before we move to the second presentation by Dr. Alex Miras, I would like to inform and ask the audience that they can post comments, questions in the chat box and throughout the sessions or until the end. Thank you. So next session will be about obesity, current treatment options, presented by Dr. Alex Miras. Dr. Alex Miras is a senior lecturer and a consultant in endocrinology and obesity medicine at Imperial College London. The specialist interests for his research group are the mechanisms of action of interventions for obesity, focusing on pharmacotherapy, medical devices, and obesity surgery. He is an active member of the all-party parliamentary group on obesity that seeks to change policy at the highest level. He is a SCOPE, which is the Specialist Certification of Obesity Professional Education, National Fellow for the UK, and Associated Editor for Surgery for Obesity and Associated Disorders and Obesity Surgery. Thank you very much. You may start presentation, Dr. Alex.
Dr. Abdeen, Dr. everyone, thank you so much for this kind presentation, for this kind invitation to give a presentation. It's a real honor, and I hope that it is useful to your listeners. Following on from Carol's presentation, I will be approaching this in a more clinical way in terms of what are the available treatments, but I will also be demonstrating some principles of treatment because it will not be able to I will not be able to cover all of the available treatments in the next 20 minutes. So the mistake perhaps that we are making when treating obesity is considering prevention as part of the treatment. Let me give you an example of what I mean by that. When someone is smoking, they are very likely to develop lung cancer. And therefore, having public health measures to prevent people from smoking or stopping smoking can prevent the development of the disease of lung cancer. But when someone comes to our clinic with a diagnosis of lung cancer, our treatment is not to tell them to stop smoking. Of course, it's a very good idea to stop smoking, but this is not the treatment. The actual treatment is to offer them surgery, chemotherapy, and radiotherapy, and we have a moral duty to do that. Next slide. With obesity, we do something different. We institute preventative measures, which of course are important for the prevention of obesity. But when patients come and ask for our help to deal with the diagnosis of obesity, when that has been made, we go back and tell them that they need preventative measures in order to treat the disease. So this is not something that has been proven to be particularly effective in the last 50 years, and it is unlikely to be effective in the next 50 years. So what these people need is treatment, and the treatment in its majority is going to be biological in nature. Next slide. So this is one of the ways that when people come to our clinic and they do already have a diagnosis of obesity, we do not just assess them based on their weight and their height, but we assess them with regards to the complications of obesity, and we stage them. We stage their disease in terms of severity. And you will see this a number of systems that can be affected by the condition. And what we want to achieve with our treatments is not just make the person lose weight, but improve their overall health and quality of life. Next slide. This is an alternative system that is also used widely across the world, called the Edmonton Obesity Staging System, and both are equally helpful and can be used in daily practice when assessing these patients. Next slide. So it is, however, also important to appreciate that different complications of obesity respond to different amounts of weight loss. So if someone has got pre-diabetes or diabetes, usually a 5% weight loss can be enough to improve their particular complication. But if someone has got established cardiovascular disease, it might be necessary for them to lose more than 10 or even 15% of their body weight to improve their particular complication. So this is a patient-centered approach. Next slide. In terms of treatments, it is important to appreciate that our patients respond to them in a Gaussian distribution. What does that mean? It means that most people fall somewhere in the middle, in the average, as we call it, but there will be a small number of people that do incredibly well after treatments, and there will be some people that lose 0% of their weight. So these are what we call a non-responder. And any treatment what you use for obesity, whether it is a lifestyle modification or pharmacotherapy or surgery, will cause a similar distribution of weight losses. It's just that the degree of weight loss will be different. Next slide. And next slide. So what we need to do is apply our treatment. At the moment, we do not have any predictive markers to help us know from the beginning whether our patient is going to respond to that particular treatment. Therefore, when I see my patients, I always tell them that we're going to conduct a trial of treatment for about 3 to 4 months. And within these 3 to 4 months, we are very likely to know whether the treatment is going to be effective. And when people respond to that treatment, so this responder subgroup that we see on this slide, these are the people that the treatment should be continued long-term, and that is really important, long-term treatment. Next slide. So I'm going to share with you some of the best randomized controlled clinical trials that I'm aware of for lifestyle, pharmacotherapy, and surgical treatments. So this is the Look Ahead study, one of the most expensive studies ever conducted, which demonstrates that an intensive lifestyle modification course, which involves meal replacements, psychological support, and pharmacotherapy, can be very effective in improving people's weight by about 8%. But what you will also notice is that there is weight recidivism alongside the complications of obesity, like diabetes, whose markers also can deteriorate over time, even if we're doing our best to help these patients. Next slide. And what we found in this specific randomized controlled clinical trial is that an intensive intervention for weight loss in people with diabetes does not result in superior cardiovascular outcomes. Next slide. What is important to note, though, from this complex table, rather, is that those people that respond very well, the subgroup of responders, actually do manage to achieve the primary outcome. They do have fewer heart attacks and strokes and deaths from those causes. And the same applies for those people that have managed to increase their physical activity, even though they might not have lost as much weight. Next slide. Here we have the DIRECT trial from the UK that has received a lot of publicity in the last few years. And it involves, again, people with diabetes, early onset generally. And it involves a very intensive lifestyle modification, which involves severe caloric restriction, followed by food reintroduction and meal replacement. Now, this is not an intervention that myself will be able to follow, because I think it is very tough to fit in my lifestyle. But if your patient can manage to achieve this and maintain the weight loss, then you should definitely continue to provide it. And in some people, this will also lead to improvements in diabetes in the form of diabetes remission, i.e. normal glycemia without the need for pharmacotherapy. Next slide. In terms of weight loss maintenance, what this randomized controlled clinical trial demonstrates is that after weight loss, the best way of maintaining weight is by giving our patients a high protein, low glycemic index diet, because biologically, this is a dietary treatment that reduces hunger and increases fullness by acting directly on the brain. Next slide. What do we have in terms of pharmacotherapy, where the landscape is improving very, very fast? 10 years ago, we would not have predicted this rapid improvement. You will be aware perhaps of the use of orlistat, which has been around for many years. It is not the easiest medication to take, but for those people that can take it, those that reduce their fat intake and do not have the problems with the side effects of the medication, it can lose to a small degree of weight loss. And therefore, in those people, this medication should be continued long-term, indefinitely. Next slide. The most modern medication that we have are GLP-1 receptor agonists. GLP-1 is a hormone that we all produce from our intestine. And if you press the next button for the next 5 times or so, you're going to see what this hormone does. It is potent, it acts in the brain, again, in the areas that Professor Leroux mentioned, the hypothalamus and the brainstem, to reduce food intake. It also acts on the pancreas to reduce blood glucose only in people who have hyperglycemia and diabetes. If you press the next button over the next few more times, please. One more. So you see the variety of organs that this hormone works at. Next slide. And when we do give GLP-1 receptor agonist as a medication in the form of liraglutide, this is the 3 milligram dose, also called Saxenda. Patients will lose about 8% of their body weight, which is 6% more than what the placebo group will lose. Next slide. These are categorical weight losses. You're going to see that some people do okay. They lose more than 5% of their body weight, about 60%. Then we're going to have the people that do even better, the 10%, that lose more than 10% of their body weight. That's about a third of patients. And 15% of patients will do incredibly well. They will lose more than 15% of their body weight. And what we also see from this collection of randomized clinical trials is that generally people with diabetes lose less weight than those without. Next slide. In terms of side effects, we have been using this group of medications for the last 14 years. They have stood the test of time. They do have gastrointestinal side effects, which in the vast majority of people are only transient and they disappear with time. The only rare side effect of pancreatitis may be an issue in a very small number of patients. And again, that is not consistent always in all the trials of liraglutide. Next slide. What do we have now? We have got the second generation GLP-1 receptor analogs, and one of them is called semaglutide. If you press the next button, this is again another next button, please. And this is a smart molecule which has been modified so that it stays in the body for about a week. So this is a once weekly injection, as opposed to liraglutide, which is a once daily injection. So our treatments are getting smarter and they are getting cheaper and more convenient for patients. Next slide. Next slide. So let's be clear that semaglutide at the moment is not licensed for obesity. It is likely to be licensed in the next 12 to 18 months. For the moment, it is only available for people with type 2 diabetes. And here you see the impressive reductions in HbA1c through this gut hormone of about 1.6%, which is really, really clinically meaningful. Next slide. What you're also seeing is that in people with diabetes, the effect of semaglutide 1 milligram is similar to that of liraglutide 3 milligrams, causing about 6% or so weight loss. And therefore, we think that semaglutide has got a pretty much equivalence with the 3 milligram dose of liraglutide in a more affordable and also probably cheaper formulation and more easy to administer. Next slide. what we have now in clinical trials is semaglutide at the big dose of 2.4 milligrams. And in this phase 2 study, what we are seeing is that it can cause even 17% weight loss in people without diabetes. Again, this is not licensed yet, but what we are seeing with these medications is now that we are getting closer and closer to something that we never thought was going to be possible, and that is to achieve similar amounts of weight loss as bariatric surgery does. So for us, this new molecule is incredibly exciting. Next slide. Even in the last few weeks, there has been advances in the field, and this has just arrived in the UK. This is oral semaglutide, so the company has managed to put a GLP-1 receptor agonist, which is normally degraded by the hostile environment of the gut, into a tablet, which is taken daily. Again, improving the convenience and the choices for our patients. And this is only available at the moment for people with type 2 diabetes, with very decent HbA1c reductions, but a smaller amount of weight loss compared to the subcutaneous form. Next slide. Next slide. There are also other medications that are available, and these vary from country to country. The one that I'm demonstrating to you here is called Mysimba. In the UK, it's the combination of bupropion and naltrexone in a tablet, which is taken twice a day. And guess where this combination of medication works? It works in exactly the same white matter areas that Professor Leroux mentioned. It is the hypothalamus, and it makes people simply less hungry and more full when they eat. It might even affect the reward value of food. And it causes about a 6%, 6 to 8% weight loss, depending on the studies that are available. And again, if it is used and it is effective, you need to carry on indefinitely. If people do not lose more than 5% of their body weight within the first 3 months, you should stop the medication, because it means it is biologically not working, and you're wasting your time and you're wasting your patient's time. Next slide. So if you press the button a couple more times, word, and a little bit more, one more please, what you're going to see is that this is the spectrum of weight loss that we can achieve with our different therapies. And there has always been a big gap, a big therapeutic gap between lifestyle modification causing up to 8% weight loss and maintenance, compared to the gastric bypass, which causes about 25 to 30% weight loss. But this therapeutic gap is now getting smaller and smaller because of advances in our understanding of obesity and advances in our understanding of how we can be smart in fooling the brain into thinking that it is in a different mode, therefore changing the set point for that specific patient. Next slide. Another way of addressing this therapeutic gap has been through the use of endoscopic devices for obesity or the metabolic syndrome. I'm only showing you this slide because it nicely demonstrates the vast majority of these available interventions. It just happens to be a slide for fatty liver disease, and they include things like the gastric balloon, a gastric plication, aspiration therapy, the endobarrier, and duodenal mucosal resurfacing. So they cause about 10 to 15% weight loss, which is great, but they have to be removed within 6 to 12 months after treatment. And therefore, whether they are going to be used as long-term treatments is doubtful, but they can be used as a bridge to a different kind of therapy that the patient might need, like bariatric surgery or a knee replacement, as an example. Next slide. And finally, we have got the most effective treatment still in the therapeutic landscape, which is bariatric or obesity surgery, as it should be called, because it's not just about weight loss, it is about the treatment of the disease of obesity, with gastric bypass causing about 25 to 30% weight loss. Next slide. This is the design of the gastric bypass, all done laparoscopically at relatively low perioperative risk, depending on the patient characteristics. Next slide. In the Middle East and in many other countries around the world, the gastric banding is becoming less popular with time because in the long term it can be associated with problems, usually mechanical problems. And the next slide, the sleeve gastrectomy is particularly popular as far as I understand in the Middle East. Again, a very good choice for patients causing similar amounts of weight loss to the gastric bypass, initially at least, even though we do tend to see some more weight regain in the longer term after this procedure. Next slide. So I'm going to finish by saying that and summarize some take-home points, which are that our treatments only work if they increase satiety and reduce hunger. The moment you hear your patients saying that they start feeling hungry on the treatment that you're giving them, these are alarm bells that your treatment is very unlikely to work in the long term. Therefore, all of our treatments are experiments. They're trials for 3 to 4 months, and be ready to make a very swift change if they do not work. Our treatment gap between what can be achieved from non-surgery and surgery is getting smaller. And finally, be more brave and adventurous when you approach these patients in terms of combining treatments together, combine lifestyle modification with pharmacotherapy, combine pharmacotherapy with endoscopic treatments, and combine pharmacotherapy even with bariatric surgery. Next slide is all of my collaborators in the UK and abroad. This is my email in case people want to ask any specific questions offline. And thank you very much for listening.
Thank you, Dr. Miras, for such an interesting lecture. Let me move to the last presentation for today, presented by Dr. Ward Al-Najm about recognizing the barriers in obesity care. Dr. Ward Al-Najm is a research fellow at University College Dublin. She holds a bachelor degree in nutrition science from Kingston University, UK, and a PhD from Imperial College London, UK, where she investigated changes in eating behavior and food preferences after obesity treatment. She is a nutrition lecturer at City College in Dublin and a guest lecturer at University College Dublin School of Medicine and School of Public Health, Physiotherapy and Sport Science. Dr. Ward holds social media campaigns for combat obesity stigma and provide public awareness to over 115,000 followers across the globe. Thank you very much, Dr. Ward. You may start your presentation.
Thank you very much, Galia. Okay, thank you very much, Galia. Thank you for the invitation, and thanks for everyone who has joined our session today at the C20. I'd also like to thank Prof. Carl Leroux and Dr. Alex Miras for setting up the scene and discussing very insightfully the disease of obesity, the facts, as well as the current treatment options for obesity. And this allows me to move on to my session and discuss obesity slightly from a different angle, and probably discuss with you and think loudly why, if all the current treatments are available for obesity, and as Prof. Leroux said, there are many more medications in the pipeline, why are obesity still on the rise? Why are we not finding solutions for this? And perhaps there are so many barriers that we can address that can help in providing patients with a better treatment and better care. So we now have learned that the symptoms of obesity include excess hunger and reduced satiation. But these are symptoms. The signs of obesity is much more obvious. It includes carrying excess body fat around the body. So the patient doesn't have so many options in terms of hiding their disease if they don't want to share it with the public or with family members. Unlike type 2 diabetes or cardiovascular diseases, where the disease that they have cannot be shared and can be kept private. So the signs of the disease of obesity frequently puts the patient as a target for negative comments like, oh, you just need to eat less and you'll lose weight, or you're obese because you don't exercise or you don't move more. Also, it puts them as a target for negative attitudes, maybe disrespect and disgust. So these comments and attitudes causes a patient to feel labeled or stereotyped, and also leads to the feeling of discrimination, which all obviously add to a patient's having stress, having psychological issues, traits such as depression, anxiety. So all together, it can lead to a reduced quality of life. Now, these discriminations and labeling and stereotyping, it can come from so many different sources. It can come from family members, or it can also come from the larger community. But very importantly, it can also come from healthcare providers. So today I want to discuss in the next few slides, what are the discrimination or what are the stigma and different attitudes that patients with obesity receive from the healthcare providers. That can be physicians, nurses, even dietitians, physiotherapists, any person who works within the healthcare center service and provides treatment to patients with obesity. They can impact on the care that the patient receives. So this is a pathway that shows certain, I suppose, attitudes that healthcare providers can have towards patients. First of all, we have some evidence that some healthcare providers can have less respect for patients with obesity compared to those without. They think that patients with obesity care less about themselves, or maybe are not adherent to treatments that they are given, hence they have the weight that they hold. So it results in less patient-centered communication, meaning that maybe the healthcare provider can just assume that the patient is not going to listen, so there is no point in providing a discussion or maybe alter the behavioral changes of that patient. So they just judge the patient based on their body or physical characteristics. We also have evidence that some healthcare providers can, if they know that the next patient walking into their room is going to be a patient living with obesity, they can immediately kind of decide or unconsciously provide them with less time. So they allocate different times to patients depending on their body weight. We have evidence that some healthcare providers provide up to 28% less time to patients with obesity compared to those. And that can be because of many reasons. Maybe the doctor doesn't want to give the patient certain treatments or discuss all the treatment options with the patients, or maybe even the patient gets or feels threatened by the healthcare provider, so they actually decide to walk out of the session at an earlier stage. We also know and have evidence that some healthcare providers can over-attribute symptoms and problems to obesity. So in one research, patients with obesity who have shortness, or different patients who have shortness of breath, can be given different treatments. If they have obesity, they are more likely to be advised to change their behavior, to change their lifestyle, so that they lose weight, and that can help with the shortness of breath. If they are more lean, they are more likely to be receiving medications for their shortness of breath. So this is a clear discrimination between the two categories of people based on their body weight. So of course, this experience of discrimination can make people or patients feel more stressed, and their feelings can be described in kind of three overlapping processes. The first one being identity threats, then we have stereotype threats, as well as felt stigma. Identity threat describes situations where the patient feels devalued just because of their body characteristics, just because of their body weight. So they feel like they are that they belong to a lower, perhaps, social identity. We know that social identity tied very well with self-esteem. Social identity can include a professional title, for example, or even financial status. And we know that these two things, professional title and financial status, can make people feel more empowered. But if a person feels that they are tied to obesity, and we know that obesity is stigmatized on its own, then that actually doesn't give patients any empowerment. It makes them feel devalued, or that they are worth less in the community. Stereotype threats can be viewed as, for example, when individuals know that they are viewed as members of a stigmatized group. So if a patient knows that the doctor has a stereotype attitude towards patients with obesity, they will be kind of trying to identify or detect these threats from the healthcare provider. So they are sitting there all the time, probably not listening very well to what advice the healthcare provider is giving, but they are just trying to detect whether this healthcare provider, when the healthcare provider is going to stereotype them or put them into the category of obese. Felt stigma as well is expectations of poor treatment based on past experiences. So once a patient feels stigmatized once, whenever they go again to the healthcare provider or speak maybe a family member who've stigmatized them in the past, they know that they are going to be receiving lower treatment. So maybe there is no point in going back to that healthcare provider because they will be stigmatized again and again. There are certain threats that can trigger the feeling of a stereotype by the patient. So we can, by identifying these threats and by highlighting them, we are able to put in strategies in place to combat these threats, as well as make the obesity care much more pleasant for the patient. So the first one is the tone of voice or the language used by the healthcare provider. As I mentioned earlier, we know we have evidence that some healthcare providers don't like treating patients with obesity. And I'm not talking about doctors who are specialized in the treatment of obesity. I'm talking about probably primary care network. I'm talking about GPs. I'm talking about doctors who don't usually necessarily treat the disease of obesity, but then they encounter an episode of or a session with a patient that they actually do need to address obesity one way or another. They don't like doing that. We have evidence as well that some healthcare providers report that they don't actually have the knowledge to treat obesity or to talk with a patient with obesity. They lack the tools. So all of these factors lead to some healthcare providers have a different tone of voice, or maybe use a different language with patients. Maybe they are harsher with patients and they don't have as much empathy. And if a patient feels these threats from the healthcare provider, they just put a block. They put a cognitive block. They don't want to hear anything anymore. They don't want to see anything anymore. They just go home. They feel more depressed. It makes everything, just the whole quality of life much more worse. Some healthcare providers already mentioned simplify the causes of obesity. They already assume that a person who walks in, who is carrying extra weight, overweight, or obesity, that they are eating much more than everyone else, that they are exercising way less than anyone else, without taking into consideration the history of the disease, without taking into consideration the biological factors of the disease. So this puts, again, extra pressure on the patient. We know, actually, for a fact, we know from a lot of studies, and I'm giving you just an example here, that patients with obesity do exercise and they do meet the WHO physical activity guidelines. In this particular example I'm showing you here, 2/3 of the patients who live with obesity do actually meet the WHO guidelines of approximately 150 minutes of physical activity a week. Only a third of patients don't. And if we dig a little bit more deeper into the reasons of why they are not meeting the physical activity, it's not because they are lazy. If anything, actually, they would like to do more. 91% of patients who are not meeting the guidelines say they want to exercise more. But they have psychological issues. They have low motivation that need to be addressed. They have pain in their joints. So instead of just assuming that the patient is not exercising and just asking them to do behavioral changes, what we actually need to do is probably refer them to a physiotherapist who can help them do certain exercises that take into consideration their joint pain, or maybe even to give them a little bit of a boost of an encouragement to do the exercises and that they can actually do it. There are even other way simpler threats that can be addressed. For example, clinical equipment. So many GP practices and hospitals might not have all the tools available for all different body weights. So for example, waiting rooms with small chairs or with armrests that the patient cannot fit in comfortably, that can immediately make them feel humiliated or ashamed of themselves. Body weight scales not meeting the higher or heavier body weight, smaller blood pressure cuffs, smaller dressing gowns, so many simple tools, and maybe assessment tools as well, diagnostic tools that cannot be used for patients with obesity. So not having all these tools available, or maybe some centers have them available, but they are hidden away because maybe they haven't used it for a long time. Just makes the patient feel humiliated. So we need to ensure that these clinical equipments do not act as triggers for stigma. So to put everything into context now, we know that the signs of obesity trigger some provider different attitudes and stigma from healthcare providers. We know that certain environmental triggers can work as threatening cues. We know that patients can be stereotyped into certain behaviors. So all of these, of course, have some patient outcome on them. They cause a patient to have much more stress. Stress on its own can be can trigger so many worsening of the comorbidities, or as well as reduced quality of life. We know that by having these stigma and stereotyping and labeling of patients, patients can avoid care. We have evidence that women with obesity are less likely to go for screenings of certain cancers because they worry that when they go for the screening, the doctor is just going to discuss their body weight with them. And they are not ready to be discussing their body weight. They want to go for a screening for cancer. So avoiding the care, avoiding the assessment can actually lead to patients with obesity present with much more complex issues and more difficult to treat just because they attended at a later stage. Patients can lose trust in the provider. They know maybe from previous experiences that they might actually not receive the correct treatment because they are just going to be given behavioral changes which won't work for them. So it results in poor adherence. We know that if patients have more motivational sessions or motivational discussions with the healthcare provider, they are more likely to adhere to the treatment than just a simple request of behavioral change. So what can we do about it, or can we actually do something about this weight and obesity stigma, and what is our role to put this on hold? We can do so many things. I suppose first is that we can encourage patient-centered communication and empathy. So as I said, motivational interviewing with the patient. So ask the patient if they are ready for a behavioral change rather than asking them to do the behavioral change. If I'm asking a patient to take maybe, as Dr. Alex Miras mentioned earlier, meal replacements as one of the treatments. If it doesn't suit a patient's lifestyle, if they are not ready to be cutting out on solid food completely and we're asking them to go to meal replacement, they will fail. The treatment will fail, not them. The treatment will fail. So also have more empathy with the patients. Maybe we can put ourselves in their shoes. We can try to assess their circumstances, take a fuller picture of their situation rather than just asking them to eat less and move more. In some cultures, it's okay to joke about body weight. It's okay, particularly, for example, now during COVID-19, particularly at the start of it, we've heard quite a lot of jokes that staying at home is going to just make us eat more now. We're all turning obese due to COVID-19. And there was a lot of jokes on the social media on this. And this is not okay. We have to introduce zero tolerance policies for comments and humor against people living with obesity. It's not okay to joke about that a temporary situation that we're going through, maybe a lockdown of a few weeks, we're not being able to go to the gym, is not okay. It's not similar to a person living with obesity for a long time during their life and they're struggling to lose the weight. We have to introduce more obesity education to to the medical field. Maybe even during medical school, we have to start teaching medical students about obesity, the physiology about obesity, all the treatments that are available now. Also educate them that maybe communication tools with patients, when to start a discussion with a patient about their weight. Is the patient ready to have this discussion? Or maybe we shouldn't mention the weight at that particular encounter. Do we have to weigh a patient every time they walk into a GP consultation, or keep the weighing when is needed or when the patient asks to be weighed? More awareness campaigns for everyone, for the healthcare providers, as well as the entire community, that obesity is a disease, is much needed as a strategy to improve obesity care. And finally, of course, provide a more welcoming and less threatening environment to patients with obesity. Provide bigger chairs for patients in the waiting rooms. Provide these blood pressure cuffs, don't hide them away in the cabinet, and make it available, make it there. Educate and train the entire staff that works in the healthcare facilities to be more welcoming towards patients with obesity, and that patients with obesity will actually listen. If we have empathy for them and we have a patient-centered communication, they will listen. They want to listen. They don't want to live with the disease. They actually want to treat the disease themselves as well, but we have to know how we do that. So I'm going to finish with this slide as well, similar to Prof. Leroux, and these are the metabolic medicine heroes, all my colleagues that I work with. And thank you very much for listening, and back to you, Galia.
Thank you so much, Dr. Ward. Such an interesting topic and presentation. So we may now move to the panel or for questions and answers, please. Before that, I would like to thank you, Dr. Carl, Dr. Alex, and Dr. Ward for such a pleasant time that we've spent for now. There is, I think, one of the comments came from Dr. Thomas Blatter. I think about his, I can't read it, but I think he says that it was full of new information, Professor Leroux. I think this is for you, Doctor. For me as a spine surgeon, obesity is indeed an issue for a spine surgeon as well. So understanding more of the underlying core issue is crucial. As Dr. Abdin said, Germany has acknowledged obesity as a disease in the country.
Yes, I actually think this is a very important point made because what we need is we need all countries to recognize obesity as a disease, because it was only when countries recognized hypertension as a disease or recognized dyslipidemia as a disease that we were really able to treat these diseases effectively. And in those countries where we have treated hypertension and dyslipidemia effectively, those were the same countries where we had a reduction in the complications of those diseases, namely cardiovascular disease. So really more countries recognizing this is the right thing for the patients, and it's also the right thing for the countries.
Thank you, Doctor. Before I move to a question from our side, I would like to also remind the audience if they would like to post any comments or questions through this panel discussion. So can we say that, can we afford a medicalized obesity if 15 to 13% of the world population have a BMI over 30%, over 30?
Maybe if I take the question and then hand it over to Dr. Miras, but I certainly think we can afford to treat obesity as a disease. And the reason is that does not mean we will treat everybody with a BMI over 30. In fact, we will treat people who have the complications of the disease where we can reverse the complications. And it is true what Dr. Miras said, is that we are limited as far as our treatment options at the moment. So we are not suggesting to give treatment options to patients if the treatments do not work, but rather, as Dr. Miras said, is we can work out with the trial of therapy whether or not the treatment works, and only if it is successful. And I think we have to be more ambitious. We have to go for 10% weight loss. Only if we achieve 10% weight loss should we continue the treatments in the long term. But I'd be most interested to hear Dr. Miras's view.
So thank you. That's a very good question, commonly asked. No one asks the same question about hypertension or multiple sclerosis or asthma as to whether treatments should be available and how expensive they are, or cancer. But when it comes to obesity, it becomes an issue suddenly. So again, this is all part of the stigma. So what we know is that those that respond well to those treatments, these treatments become suddenly very cost effective. Bariatric surgery has got a high upfront cost, but actually in a very large number of patients, they're cost effective in the long term. So therefore, yes, we should. With regards to pharmacotherapy, again, if we have stopping rules, that is very likely to increase our cost effectiveness. We also need to remember that medications might at the moment be on the expensive side, but like proton pump inhibitors or antihypertensives, eventually the prices will be reduced. And this is already happening. Another thing to say is that if we, which is a very practical approach, is if we take 1% of the budget for the complications of obesity, so money that goes to the cardiologist or to the endocrinologist or the orthopedic surgeon that treats the complications of obesity, if 1% of each of those budgets is given to obesity, then yes, we will be able to afford these treatments.
Thank you very much. Thank you. So to move to another question, now by declaring obesity disease, do we not run the risk of removing agencies from people with obesity?
I think many politicians are asking that, and policymakers are struggling with this idea that if we declare obesity a disease, does that mean that the whole population is suddenly going to run to fast food outlets and start eating vast amounts of calories that they don't need? I must say, I work with people living with obesity every day, and I have not met one person in my clinic who wants to have the disease of obesity. But what we have struggled to do is we have blamed people, and as Dr. Al-Najim pointed out, therefore people don't come to seek help. So we need to change our public health message from the current message, which is move more and eat less. We need to change that to seek help. But then when people come to seek help, we have to give them agency. We have to empower our patients, not only to understand the disease that they have, but also to understand the treatments that we have. But I'd be most interested to hear Dr. Al-Najim's view, also when it comes to how stigmatization can reduce agency and reduce empowerment of patients.
I totally agree with you, Prof. Leroux. I think patients, when you actually explain to them that their weight and the difficulty that they've had to lose weight, the physiology behind it, the biology, all the hormones, when you explain it to them, you actually have a lot of emotional feelings coming out of patients. And the whole attitude, this whole encounter between the healthcare provider and the patient suddenly changes. The patient feels that they've been listened to, that they've finally have a clear picture of their disease, because they've always been stigmatized against their weight. And they actually, again, maybe we need more research and more evidence for this on a larger scale of patients. But my personal experience as well matches yours, Prof. Leroux, and I find more compliance from patients. I find more adherence to treatments, that they are actually suddenly more eager to explore with the different treatments rather than maybe sometimes you tell patients you need medication and they are like, no, I can do it with the diet only. But then suddenly, by explaining the physiology and the obesity is a disease, they are more open to receive different treatments, including medication and obesity and surgery. So it enhances the treatment.
So I believe this is a worldwide problem. Sometimes we think it's a regional thing because of cultures, etc. But it seems that our place, such your place, maybe the States, Australia, everywhere, it's becoming like really an issue for the patient or for whoever is having obesity to start, and for the first step at least to go to ask and seek help, because I think because they have a massive amount of information since childhood that it's their problem, it is their choices, it is they're not moving, they're not playing, they're always on the, for example, screens, they eat high dense food, it's always them. Where sometimes you see in the same family, two brothers or two sisters, they do eat the same food maybe, so they share the same environment at least, and one is having really a problem with obesity and the other maybe don't share this. And there when they start like really picking up on this child who's having this problem at home, for example, or in the family, and this makes it even more difficult. I remember once we had a program for some patients who's having obesity. We called it Harrir. We had some psychologists and we had some behaviorists, we had some nutritionists, physical. The first thing they asked, and then we tried to do it in a cafe style, so they will not feel this, and we were taking like 6 to 8 people. First thing they told us, please don't put any signs on the door that we are the people who are having obesity and we're sharing our thoughts. It's like a group therapy, with some consultants around sharing like an hour. And it was really excellent, and we had really good feedback. But again, they have this problem, and when I sat with them at the very end, the main problem was the stigma and how can they go to seek help, and they're shy, and if they will go and if they fail, actually the problem, if they go to the doctor, for example, and they went back and fail with it, this is the catastrophic part of it, so they'd rather not to start it anyway. So yeah, so maybe I can just please move, because of the time, let me move for a third question that I would like to listen from the panel. What will happen? What do you think? This is a question for Prof. Leroux, for Dr. Miras, and for Dr. Al-Najm. What will happen if we do not declare obesity as a disease?
I think we also have to be honest with the public and with ourselves that if we do not declare obesity a disease, the sky will not fall. The end of the world will not come, if we don't declare it a disease, because not everybody in the world can develop obesity. This is a biological disease, and understanding that the people who have obesity, it's outside of their control, as it is for many people who are underweight, who want to gain weight, but that's also outside of their control. So not everybody in the world will develop obesity. But if we do not declare obesity a disease, we will harm individuals, but we will also harm society. Because we are now developing the tools to treat obesity as a disease. So we have the opportunity to allow individuals to gain health, but we also have the opportunity to protect our economies from the consequences of obesity complications. So I think this is a real positive step that we can take that's not only going to bring health to individuals, but also bring more economic security to our countries. Mm-hmm. Maybe Dr. Miras, if you want to add to that.
Yeah, I wanted to add that I remember when I was growing up in the 80s, I was still young, but I was starting to learn about HIV. and the stigmatization of HIV back then, which actually what happened is that it caused people with the disease not to present, make them hide, made it potentially transmitted to other patients. And HIV has actually now become a big success story in the space of not many decades. So eventually it was recognized as a disease, not so much, I think, because doctors push for that, but because patients push for that. They lobbied about this being a disease. Lots of celebrities did that. A lot of money was poured into research for HIV, and now it is a completely manageable long-term condition that no one really cares about much anymore. It appears on the list of diagnosis, and no one is scared as to what to do with the patient. And therefore, if we follow the same paradigm, we're going to do exactly the same for obesity. And the drugs for HIV initially were very expensive. And everyone said, oh, do these people deserve treatment? And now the drugs for HIV have become less expensive and very affordable. So I consider it to be very similar as a story.
Thank you, Doctor.
I think recognizing obesity as a disease is going to require way more efforts than what we have now. We are moving against a huge wave of resistance from the communities, from the general public, from stakeholders, from politicians, there are so many things against just us recognizing obesity as a disease. The problem with obesity, I think, where I can kind of understand why people cannot accept that obesity is a disease is that it doesn't happen overnight. You just don't suddenly get, it's not a virus, it's not a rash that you suddenly get on your skin overnight. It happens over time. Hence, people think that, okay, well, if just people take responsibility and stop eating, they will not develop this disease of obesity. They just cannot understand the genetic and the biological factors that allow obesity to be such a slow developing disease. It will happen. We will require a lot of awareness, a lot of education. It will happen eventually. But I think what I would hope for is that it will happen sooner rather than later, because prevention is not working effectively, as we can see, and the rates of obesity are on the rise.
Thank you, Dr. Najm. I don't know, in a couple of minutes, Dr. Karl, would you like to sum the session before I go up with the recommendation?
So if I may summarize, I think this has been an excellent symposium where we have heard that obesity should be recognized as a disease. We heard about the effective treatments that are emerging. And we've also heard about how stigmatization is reducing our patients to seek and access help. I think we have the tools now to really make a difference to our patients. So thank you very much for this wonderful opportunity and this very impressive symposium.
Thank you very much, Dr. Karl. So let me, before thanking everyone, let me say up the recommendation. Then I don't know if you all agree with me that obesity should be officially recognized as a disease by 2020. Hopefully, our report will go up to the G20 countries, and we'll have good news then from their side.
Not long left.
We'll see how.
Not many months left.
hopefully. So I would really like to thank you, Prof. Karl Leroux. Thank you so much, Dr. Alex Meras, for your time. Thank you so much, Dr. Werd Najm. It was a pleasure having you with us in the C20 held by G20 in Saudi Arabia. It was a pleasure having you all. I would like to thank all the audience and whoever engaged with their comments and questions. And whoever are members of the civil society organization, the C20, they can still register to become also and see more, watch more, and attend more sessions, interesting sessions. And if they have any other thoughts about it, they may also share it by the hashtag of C20 Summit. Thank you so much for giving me the opportunity to run this session and to moderate it. Thank you.
Very well done.
Thank you so much. Thank you so much.